this current scenario, what we are going through, what we are passing through, a very pandemic situation, it's an unprecedented situation, a very rough weather we are sailing. It's particularly in healthcare establishments, we are facing tremendous kind of a problems related to particularly two areas, the operationals and the finance as well. Finance, we all know, because all the healthcare service providers, we all understand how we are really suffering with this your financial part, because almost none of the hospitals we are managing more than 50% occupancy. So 50% occupancy managing with huge amount of your fixed cost, that is your manpower cost, and the increased cost of this your personal protection gears and all. That's a tremendous tough time, challenging time for any healthcare providers to cope up with the situation. That is a one part. Many healthcare facilities also we have seen over the time, this last 2.5 months, the COVID situation time, almost 3 months now we are going through. There is many of the healthcare facilities close their establishment because of the seal, because of the contaminations taken place. Your healthcare workers got infected. So there is a lot of issues came up in this particular in this last 3 months time. Even it has been seen that the facilities are further financially strained due to the cancellation of elective surgeries and all. So financially, if we see there is a less number of OPD patients, I'm talking about the COVID time, and the less amount of number of footfall in the OPD. There is a no footfall in this your any international travelers. There is a restriction for this your elective procedures. So the whole thing is a diagnostic test absolutely nil. There is no patients in the OPD. There is elective procedures. If we are talking about indoor, where we generate revenue actually from the surgery and all got stuck because of this crisis. So, but this crisis actually has deepened further with the operational issues. What are the operational issues we are facing, which has been further depend on this your financial crisis actually? There's a cross-infection of staff. Actually, I have already mentioned that is within the hospital. That's one of the operational issues, the challenges. Employees contacting the infection from the community. One way, this is the staffs are getting infected in the internal way, COVID, non-COVID, and all those protocols. But though it is much number of less, because we are all quite advanced in making our own SOPs and protocols that we can discuss later. But even we have started observing, witnessing that the good number of infections from the community, it is spreading as well, and the staffs, they are coming and joining the duty with this infection from the community. Staffs not returning to work, that is a big issue. So we have seen that even it has been happening, each and everyone we are facing, the doctors, the nurses. The nurses, it's a bulk number of nurses from the Northeast and Odisha, they left the place without any proper information, 700-800. That all we have seen in 1 month, 1.5 months back. That is also one part. And whoever have gone on leave, they are not coming back. So there is a less number of staffs in the work front. Increased burden due to additional precautions. Yes, of course, there is a lot of precautions that we are taking. So that is an additional burden that we can see. Resources that establishments need to implement to prevent, that is also a big part for the healthcare, to keep every staff, the healthcare workers, to keep safe. That's one area of concern. And protect our employees and facilities from COVID-19, so that there should not be any further kind of a contamination, and all those things should take place. So that is also one big area of concern for the healthcare sector, as we are talking about the operational issues, which is depending further with this your financial issue. Now, this almost we are at the end of the verge of the end of this COVID, your lockdown and all. And there are some kind of a relaxations taking place. Transport started, movement started little better. People started coming out of the lockdown situation. There is a unlock one has started. So that is also now the question of this is how we can restart the healthcare currently, which has been postponed. That's the patients are not coming to the OPD, the investigations not taking place, and the surgery that is surgery which has been, elective surgery has been placed before, planned before, is not be taking place. So how we can start this care, ultimately preventive care in phased manner. Actually, absolutely, we'll have to make it in a phased manner. That will be the discussion today. In recognition of the need to preserve hospital capacity, that we need to understand states have prioritized. Now, if we say the states have prioritized hospitals in efforts to reopen segments of the economy. So that has already been done by the government regulations and all. Many of the state guidelines as well, they are showing for reopening or resuming the service lines and require healthcare establishment to exercise significant judgment in determining when and how to safely reopen and deliver care. That also being the guideline is already replaced. Now, hospital must consider a variety of legal issues as well. Whenever we are slowly we are opening up, there will be a lot of issues, legal issues will come up. So that also the hospital caregivers will have to keep it in mind, and providing care in the substantial numbers of non-COVID-19 patients as well, because we are all talking about COVID patient, but non-COVID patient, when you will start this your elective surgeries and all. So the protection for this your legal part also will have to take care. Now, understanding all these needs, the operational issues, the legal issues, the financial issues, the protection of your employees and all. So this, in this need of our actually CII, along with the Mindray, India is organizing this webinar to help healthcare professionals to identify issues by illustrating some of the questions that hospital, operational, legal, all those that we can address and the part of the reopening of the strategy. So this is a very, very important kind of a discussion as we are just started reopening. All the eminent speakers are there who will discuss about various topics, and we can understand more about what are the steps or the precautions one healthcare service provider should take. So this, with this kind of my opening remarks, I'm sure that everyone will be, everyone is excited to understand, enrich one of, and definitely there will be a lot of vital takeaways to understand the situation much better way. So I thank you, all of you, for joining with this session, and Abhishek, you can take it forward now.
Thank you, Chairman, for your insightful views. I would request now Prashant Sharma. He's the chairman. He's the co-chairman CII subcommittee and managing director Charno Hospitals, to give the theme address for today's event. Over to you, Mr. Sharma.
Prashant, you're on mute.
Unmuted. Can you hear me now?
Yes, loud and clear.
So a very good evening, ladies and gentlemen, and a very warm welcome to the CEO Roundtable on Rebooting Healthcare Setups post COVID-19. Well, no country was really prepared for what happened when COVID hit us. While some countries dealt with it better than others, the focus on how the healthcare sector was broken to begin with, and how we can use this pandemic as an opportunity to slam hard on the reset button and restart healthcare in a more meaningful, safe, and fiscally responsible manner in India.
Prashant, we can't see you. Your video is off.
He's actually visible, Rupalidhi. I can see him.
Well, my screen shows my video and audio both are working. Somebody, can you please confirm, Abhishek? Or
I can see you.
right.
It's perfect, sir.
Yeah, visible.
Yeah, carry on, Prashant.
Can also see you.
So, in association with Mindray, we are organizing the CEO's Roundtable to enable hospitals to identify the issues which are pivotal to the reopening strategy. It would address very critical questions and illustrate further the points that the hospital, operational wise, legal, compliance staff would have to deal with the reopening strategy. Well, I have studied many financials of almost all hospital models, whether it is chain or large nationwide chains, standalones, and seldom have I found any hospital to post more than 3 or 4% profit numbers. And those are hospitals which have got very huge occupancies of 70 to 80%. Those are hospitals which have got nice RPOPs, low LOS, well run, well managed. So in a given good time, have reported numbers which are less than fixed deposit rate numbers. And the profit numbers, even if you make 100 of revenue, 95 rupee would go into the expenses, and the balance 5 rupee would not really come into your bank account. It remain as outstanding with most of the corporates or insurance schemes or other schemes. So we have been cash strapped from day before the pandemic hit us, and now here we are. This is the COVID epidemic, the pandemic. The volume drops from 80%. The staff almost vanishes, whether it is the top tier consultants or the lower level healthcare workers, including housekeeping. The social stigma, the country which applauds its healthcare givers on one given Sunday at 5 p.m. with lights and thalis, and the second week we see so much action that the staff is so stigmatized that unable to step out of the complexes or go back to their homes post duty. Then hit us the migrant labor workforce absence issue. We were literally paralyzed in the middle of a massive demanding situation. And here, with all this, is now we are entering into a phase where the lockdown has been removed, and we can expect a massive avalanche of patients to hit us from all sides and corners. Well, the scenario lies there is no cash in the system, there is no savings, there is no debt available which you can tap into. The volumes are not promising, the cost of operations are extremely high. I have not witnessed any or read any situation which is as challenging in any sector as healthcare it is right now. Well, today we have a very with us. We have experts and leaders from literally the best hospitals of the region. We have with us Mr. Rupak Barua, Director and CEO of Amri Group of Hospitals. Not only is a well-known, name in the healthcare sector of India, he did his postgraduate in marketing. He completed the MDP in hospital management from IIM Ahmedabad and IIM Bangalore. Prior to his current position, he has worked in many leading hospitals like Workhard, Peerless, Duncan Gleneagles, to name a few. We have with us Mr. R. Venkatesh, Regional Director of Narayana Health. Venkatesh joined NH as Head of Finance at R. Tagore Hospital, Institute of Hospital of Cardiac Sciences, and then took over as facility. He holds a bachelor degree in commerce from Calcutta University, and as a chartered accountant and holds associate membership of ICAI. He has exposure of advanced financial accounting and around 15 years of experience in P&L management and operational issues in healthcare facilities. We have Ms. Richa Singh Devgupta. She is a Senior Vice President and Operations for Fortis Healthcare. In this role, she is responsible for the healthcare business of eastern part of the country. She is actively involved in growing the business in the eastern part to increase the company's profile. Richa has more than 16 years of experience in some leading private healthcare settings in different parts of the country, with skills in operations, performance, quality improvement, and business development. She has expertise in dealing with different formats of healthcare delivery models. We have Dr. Simardeep Gill, who is the Group CEO of CK Birla Hospitals. Dr. Gill has over 18 years of experience in the sector. He is a qualified clinician, proficient in building teams, improving the efficiency and competitive performance of businesses, and is extremely good at people management. He has proven ability to work in different cultures, regions, and is a true team player. We have our own Dr. Rupali Basu, Director and CEO of Woodlands Multispecialty. Dr. Basu is a medical graduate from Arjikar Medical College and has postgraduate training in health and hospital management from Harvard and Delhi University. She is known for her pioneering work in bringing quality systems and accreditation in healthcare in India. Her contribution in developing super specialty tertiary care hospital services in Eastern India, specifically in cancer, cardiac, and emergency care, is instrumental in bringing back the confidence of the public and the healthcare sector of the Eastern region. We have with us Mr. Animesh Dey, Regional Business Head of Mindray Medical India. Mr. Dey has over 20 years of experience in healthcare equipment, and he is a certified lean management professional. He has an electronic and telecommunication engineering by background in his education and has done his management from IIM Calcutta. Now, this is the given scenario of the challenge. Now, these are the given experts. I cannot think of a better panel to address the situation on how to handle the current given scenario. Now, we have a very interesting panel discussion ahead of us. But before that, we have with us Animesh, who will talk to us about the current modalities. Over to you, Animesh.
Thank you so much, Mr. Prashant. So, a very good evening and a very warm welcome from Mindray team to all the delegates and all the attendees who are attending this program. We and myself is Animesh Day, as I told you, and we have this wonderful and timely panel discussion today, which is absolutely required for this industry at this point in time. So I will take you through what Mindray as an organization is and how we are supporting COVID-19 fight with all the healthcare fraternity. So I will just take you through my presentation. So just let me know if it is visible to all of you.
Yes, it has come up.
Yeah. So Mindray India, we have established this organization in India in year 2007. As an organization, our vision is a better healthcare. So better healthcare for all, and our mission is advanced medical technologies to make healthcare more accessible. So this is our vision and mission statement. If I talk about, so now you can see this is our Mindray head office. So this is actually situated in Shenzhen, China. We have established Mindray as an organization in 1991. We have 8 R&D center and 40 subsidiaries all over the world. We have more than 3 lakh square meter of manufacturing facilities all over the world. Our business revenue last year, it was 2.3 billion. We employ almost 10,000 globally, and we also export in 190 countries. So this is Mindray India office, which is actually situated in Gurgaon. This is the complete Mindray.
Animesh, the bandwidth is low. Can you please turn off your video if required and then continue? Animesh, we cannot hear you. Turn off your video, please.
In some way, Onish is not responding. The network is not there, or out of the
Probably
network.
he is not having signal.
Abhishek, yeah,
Is anybody else here from Mindray?
Yes, this is Deeptesh. I'm the marketing manager from Mindray. Thing is, probably the network is not good there at his end. So we are trying to connect with him. He's probably going to start in next 1 minute, I guess.
We'll wait for him. Me and my team, we visited the Mindray Center a few years back in Schengen, and they have an awesome office. The lab, which has been set up as a demonstration lab, is something out of the movies. It is better than any hospital that I've visited. The equipment which they manufacture, especially the T8 monitors in the ventilator series, which is US FDA approved, is really state of the art. I have not seen such machinery by even many German players. And the hospitality was super fantastic. The lunch which they served us was, I think, 56 course or something like that, and it was a real experience for all of us.
So I think Animesh is facing some trouble. I'll continue from here, requesting Abhishek to share the screen, please, so that I can go through the slides. Debojyoti, Abhishek, are you there?
Just sharing my screen, Diptesh. Just a second. Diptesh, can you see the screen now?
Yes, thank you so much. And really sincere apologies to all the viewers right now for this unintentional pause. I'll quickly go through the slides. Yes, our vision is to better the healthcare for all, and we are striving throughout our day in, day out for that. And our mission is to advance the medical technologies to make it more accessible. The accessible word is very core to our heart. And whatever technologies we have, they are all cutting edge technologies, all best in class, and they are accessible and affordable by the mass in India and in any developing country for that matter. That makes it unique and different. Next, please. Yeah, it's an MNC which is established way back in 1991, and it has a even longer history dating back to even 50 plus years more than that, because of the acquisition of various other platforms in patient monitoring platform, namely Datascope, Zonare, SK Medical, and many other. We have 8 R&D centers globally. Mindray India is one of these 40 subsidiaries that we have. It has one of the largest manufacturing facilities floor size wise. Business revenue this year, it has almost touched $3.5 billion, and it has a global employees base of one of the largest in the industry, exporting to more than 95% of the global coverage of the countries. This building is our headquarters, and as Prashantji already mentioned, the below portion is the pantry area only. So it is quite a long and big facility. Next one.
Yeah, Diptesh, I'm back again.
Yeah, please, Animesh, from here you can continue then.
Sure. So I'm sorry for the technical glitch. Although I'm in office, but I don't know what happened actually. So this is Mindray India head office in Delhi, Gurgaon. So here, all of our head office is there for India operations. Next page, please. This is the entire Mindray India team. We serve with this team to the entire country and entire healthcare fraternity of Indian market. Yeah, next. So these are the organization which Mindray has close collaboration with for our innovations, like organization of Datascope, which is a USA based or a patient monitoring company. So Mindray has taken over this. Ulco Medical is basically a company who manufactures anesthesia workstation. Zonare, you all know, it's a US-based organization taken over by Mindray, and we are now manufacturing this equipment here. So, and maybe in the next slide, if you can go into the next slide. So this is our global presence, market penetration. As I told you that in China, over 110,000 medical institutions, just be on the last page, please. So 110,000 institutions are actually using Mindray products. So, yeah, thank you. 99% of those medical hospitals are top tier hospitals. Every 2 hospital out of 3 in US, they are using Mindray products. And in rest of the world market, we have 20 plus subsidiaries. Next, please. Mindray is a technology company, and we invest a lot of our revenue percentage in innovation and R&D. So as you can see, 10% of our sales and revenue goes into R&D. We have R&D talent pool of 2,200 plus. We have applied patents of 2,900. And every year, you can see at least 7 to 12 new products we are launching and bringing into the market. Next. So these are our product range to offer to the customer of healthcare industry. We have patient monitoring and life support and surgical unit business. Then we have in vitro diagnostics, and we have ultrasound imaging system. So I'll start with patient monitoring and life support. Next page, please. Yeah, this is our patient monitoring and life support range of products, where we have a range of patient monitors, anesthesia workstation, ventilators, defibrillators and AEDs, electrocardiograph and infusion pumps. Then next page. This is our entire surgical equipments portfolio, where we have operating table surgical lights, endoscopy camera system, and all medical supply units with surgical hand instruments. Next slide, please. Equipment support given in pandemic period. So pandemic period, there was a lot of scarcity of equipment coming into India. But as a company, Mindray has overcome that, and we are the topmost, we are the biggest supplier of ventilator and patient monitor in India in this pandemic situation. If you take it from month of January to month end of May, we have supplied almost twice the equipment of our nearest competition. So these are the few names where we have supplied ventilators, and we have given entire complete COVID ICUs we have made for these hospitals. AIMS Rishikesh, BR Medical Supply Corporation, then KSMCL, RIMS Ranchi, Icon Calcutta. So these are the few names which I would like to refer, where we have given entire support in this pandemic to overcome the equipment shortage. Next, please. This is our in vitro diagnostic products. As you all know that this pandemic situation, this reticulocyte counts and other CBC counts and other things in hematology is most important to monitor the COVID patients. So we have these installations in AMRI, Medica, Bellevue, General Hospital, Disan and KPC Hospital. And we are keep on supplying the reagents. In fact, taking all the burdens, wherever the supply chain issues were there, but we never faltered on it, and we have supplied as and when it is required. Next, please. So this is our biochemistry analyzer. Again, in biochemistry analyzer, sodium potassium monitoring is also very much important in case of COVID patients. So those biochemistry analyzers reagents also we have supplied within this COVID period to help and support the entire industry. Yeah, next. This is our CLIA family, where we can measure thyroid, tumor markers, and diabetes and cardiac markers and metabolic markers. So these are all by us within this last 4-5 months COVID period. We have not let our customers suffer for a single day. Yeah, next please. This is Mindray product basket for ultrasound. We have black and white and portable ultrasound. We have portable color Doppler ultrasound system, and we have card-based ultrasound system also. Yeah. Next, please. This particular model T7 we have supplied in so many ICUs or point of care hospital where these equipments are being used specially to monitor lung ultrasound in COVID patients, and these are also point of care devices which are being extensively used in fighting COVID-19. Yeah, next. So let us all fight COVID-19 together, and Mindray is always will support the entire industry in whichever way, whichever equipment is required. We will supply that and support the entire industry. Thank you so much.
To you, Mr. Sharma.
Right. So good evening once again. Since we are a little bit behind schedule, I would skip the introductions which we already have done and delve straight in the panel discussion. Now, we have 7 very interesting topics today with us, and we have 7 very distinguished speakers. Without further ado, I would like to request Dr. Mr. Rupak Barwa, Chairperson for CII Healthcare and representing Armory Group of Hospitals, to kindly give his views on government regulations, SOPs, and protocols, and help us understand this aspect much better.
Thank you, Prashant. So already I have in my opening remarks, actually, I had made some comments actually about the pandemic times, what we are going through, passing through. And this is a global pandemic situation. If we little bit, if we closely overview this year, the situation, last 6 months journey actually. So this is this pandemic situations started maybe around this year, mid of December in China, and now we have taken this pandemic, I mean, or infected from some other places, and it is a global situation, has become, it's a global situation over the time in last 6 months. So far, India is concerned, if we see closely, if we observe, that is, it started maybe beginning of March, actually, the first case detected. And in Kolkata, it came maybe 17th or 18th of March, the first case started. There was a meeting held with this your Honorable Chief Minister with the private healthcare sector, where the Chief Minister actually asked for support of the private healthcare, because we could understand that private healthcare is one of the major important part of this healthcare delivery system, because 60% of the private the beds are dominated by the private healthcare. Now, over the time, if you see that the global this situation, there are multiple bodies actually who are giving this kind of guidelines and all. If we are talking about the guidelines, if we are talking about the challenges the private healthcare sector facing, so each and every day there was a new challenge actually we could see. There are multiple guidelines initially started by this WHO, then the national guidelines, and there is the ICMR guidelines, and yes, of course, there is a Bengal government and our state government. There is some of the guidelines are there as well. Now, the guidelines, if we see initially, there's a two different kind of guidelines. One for the common people, the guidelines like your social distancing advisory, or your travel advisory, cargo movement, all those kind of guidelines. And there are clinical guidelines started coming up. There is a how to manage a different kind of a situation so far the COVID patient is concerned. By the time this lockdown started, and the hospitals actually started facing the huge issues started from this year, March 23rd or 24th. The extreme situation started coming between this March 23, and still it is going on. And maybe now we are discussing about the rebooting of the healthcare. But if we see the guidelines and the advisories from the different nodal bodies, just to navigate our ideas and all how we can navigate the situation in this your COVID patients. Now, as we have discussed earlier as well, there is an operational issues and the financial issues. Financial issues, so far the guidelines is concerned, no way linked with the financial issues, but all those guidelines to some extent we converted to this our individual SOP or the protocols just to little bit just to protect ourselves in terms of your contamination, and is maybe to some extent we can overcome the financial situation as well. Now, once this the COVID situation we are talking about, this is a very new guest. This is just is a 6 months old guest, and there's a body actually is trying to find out the behavior of the COVID. There's a behavior of the virus, and the whole world actually doing a lot of study research is going on for vaccination, for the what kind of medicine we can start, and so there's a lot of research and the academic part is happening across world. There's many large top universities are involved, and healthcare institutes are involved as well. Now, if you see this year, during this year pandemic situation, what we started at the healthcare service providers in terms of delivering the proper kind of medical systems and protect our healthcare workers, because the healthcares, we are the frontliners. We are the frontliners. We are facing the major trouble. We have faced the major trouble, and still we are facing the trouble. Now, every day it was a learning for us. Every day we are learning new ideas, how to protect ourselves, how to protect our healthcare workers, and how to give better care to the patient, those who are suffering. Now, if you see the guidelines we are talking about, there's a various kind of guidelines taken up, but every day what we have learned actually that the guidelines by the government, but in the major healthcare providers, if we see individual hospitals, we have our own system, we have our own protocols, we have our own medical advisory board, we have all the expert clinicians on board. And we could see that is that the guidelines which the government is making or the WHO is making, actually we are converting those guidelines. That's a yes, of course, that's a guideline, that's an advisory. Considering those advisory and guidelines, we have taken up, we had made our own standard operating protocols. We have made our own system so that we can make our hospitals safe as well, and we can give proper care to the patient. Many of the hospitals, some of the hospitals, yes, if we talk about my AMRI hospital, there's a one hospital we had extended to the government as a COVID hospital. So managing COVID hospital is one challenge, but I think there is an equal challenge is that managing a hospital, managing a healthcare establishment with both of the COVID and the non-COVID, both combining, because there is a initially what we are talking about, that is the suspected one or symptomatic one, but gradually what we have seen over the time, that the symptomatic has become asymptomatic now, and there is no travel history. There is an all your local contamination is from the community, and that has become a major challenge actually. So whatever the SOPs and the protocols we are preparing daily basis as per the government guidelines, government notifications, or government advisory considering. So there is a changing of the SOPs and the protocols is a major challenge. We could see every hospitals, I think they have their own standard protocols. They have made all these standard system they have made. Now, that is the major challenges. Now, what we are talking about now, the COVID situation. We'll all will have to understand that COVID situation is it's a journey actually. It's not a destination. COVID is going to stay with us. It is not going to leave us, at least for some time. We don't know what is the sometime, what is the... So we'll have to go through this COVID situation, and we'll have to see how best way we can manage this COVID, and we can look for the post-COVID situation. Now, the protocols and the policies or the management, standard management we are talking about just to manage the hospital right now. So one is the post-COVID COVID situation and the post-COVID situation. Now, whatever we have learned so far during these last 3 months, that's an enormous kind of knowledge we could gather. as a part of the managing the hospital. We have managed, so each and every one of the service providers, we have accumulated a lot of knowledge out of this your situation, because daily basis we are learning. There's a lot of situational changes, scenario changes happening, and we are coming up with a new system, new protocols. Now the major protocols right now, it's yesterday the protocol was how to take care of our healthcare workers, how to give better service to the patient and how to treat these your COVID patients and the non-COVID patient. What are the protocols? This is the green zone, orange zone, red zone, whatever way everybody has taken care. Now the major discussion is not now we'll have to talk about, because we have learned enough. We have created lot of SOPs and protocols for the yesterday's situation. Now that is the more of the operational situation to handle. Now the question is now the post-COVID situation, the unlock situation, how we are going to handle the financial part, because operational part we have handled to some extent. Yes, of course, there are some changes, but now when we talk about the financial part, because the huge amount of financial losses that we have already discussed, 50%, less than 50% occupancy, there is no footfall, OPD footfall, there is no your elective surgery cases. Now it is going to open up, and we'll have to see how best way possible we can start the normal operations, new normal way, and how we can accept the OPD patients. What are the new protocols will take place? How the safety measures we are going to take care of the patient, those who are coming from for registration, and our healthcare worker, those who are day in day out, they are attending the patients as well. Once that is there, then conversion will take place either in the investigation part, diagnostic part, and the other part is the indoor part, or the elective surgery and the indoor cases. Now, there is two challenges as well. Whenever you are taking the diagnostic part, what are the protocols will follow for doing CT scan, for doing MRI, for doing ultrasound, for doing echo, for doing more of these your gastrosurgical procedures. So that's the question is now, that's a major patients, even out of almost 20, 25%, 30% of the patients coming positive now. Now, one of the major challenges which we had actually earlier, that is the testing facility. Testing facility was not there. Yes, of course, we know we had gone through various kind of situational ups and downs, and the testing is now is possible. Almost many of the private hospitals, diagnostic setups, they have been approved by ICMR and the NABL now to go for the testing part, that is either the RT-PCR or the open system or the closed system, and more or less we are now self-equipped to do the testing part. Now the question is, the one part is the testing part, and the other part is that that number of patients increasing as well, because each and every patient you will have to identify that is a suspected patient, though there is a absolutely asymptomatic mild part. So that is one part that we'll have to understand. That is a lot of protocol. Otherwise, you will not be able to overcome the financial situation, because more number of OPD patients will come up, more number of OPD patients will come up, more number of surgical procedures will take place. If any eventuality happens, then again we'll be in a very in the loser side. So we'll have to be very careful. So for the OPD protocol is concerned, we'll have to be careful for the surgical protocol is concerned, and we'll have to be careful for the treating of the other non-COVID patients, non-surgical patients as well. That is one of the major part that we need to understand. So these are the major points, Prashant, that is, I think I have taken time. So the protocols are changing. There is a pre-COVID, post-COVID protocols and the post-COVID protocols. There are two parts. Now we'll have to overcome the situation challenges, and we'll have to come up with a lot of post-COVID or managing the hospital in a normal way in this COVID situation. What are the protocols should take place? I think that is our major concern, and almost all our hospitals actually are quite well equipped with these protocols and the policies in place, and will be able to overcome the situation within a short time. Thank you, Prashant.
Thank you, Rupanda. Thanks a lot for the overall scenario. You have always led the private healthcare sector from the front. You have represented us in the government. You have spoken about us, for us, on all our causes, and we look up to you for constant leadership in the future as well. Well, that brings us to a very important part as to this scenario has been changing drastically every 3 or 4 days. The numbers are changing. Our response to the numbers are changing. Government directives are changing. The modus operandi is also constantly changing. Where we stood a few weeks back, and where we are right now, has seen multiple generations of change in ways of operations, whether it be testing, be it admissions, be it surgeries, or be it discharge policies. I would like to now invite Dr. Rupali Basu to discuss with us regarding the testing aspect, because to the common man, as well as to many of the healthcare workers, this still remains an area where the clarity is not very well seen, and we would love to learn a bit more about how we stand now. Dr. Basu, please.
Good evening, everyone. So on testing, I think Rupak gave a little bit of an introduction on why should we do testing and what are the testings that we have. I think the three major buckets, if we talk about the testing, is that who should be tested, why should we do the testing, that part. What are the indications of testing, and then we can talk about that when do we do the testing, and then what are the types of testing that we have, how to do the testing. So if you go to the first one, that who should do the testing, you should know that this is testing for finding out the infection of COVID-19 virus or SARS-CoV-2 infection. So acute infection is what we are trying to test out through the testing facilities. Now, who should do the testing? The first bucket is actually identified very strategically by ICMR, and you all by now should know that there is a specimen referral form of ICMR, which is a two-paged form like this. It's a two-paged form where you have actually the patients are categorized. So patients need to be tested. Now, patients can be also asymptomatic, as Mr. Barua was talking, but let me talk about the category of the patients that who can go for testing. There are 10 categories, and it is very well defined. Category 1 is symptomatic international traveler, which was the first one happened when we were, this disease has come from abroad, so it came through the international travelers. So that was the first one. That continues to be the first category. The second is symptomatic contact of lab confirmed cases. 3 is symptomatic healthcare worker or frontline worker. You all know that if the symptoms of is all the symptoms of the disease, which is we all know about the symptoms of the disease. I'm not going into the detail. They're all respiratory distress, the cough, the fever, and of course there are tests, situations of test. The symptoms, I'm sure someone will talk about the symptoms. We all know about the symptoms of COVID-19 positive. So these are all symptomatic cases where you have to do category 1 to 3. Then hospitalized SARI, which is SARI is severe acute respiratory illness. These cases also will have to be tested. Asymptomatic. Now, these are the symptomatic ones. Then comes the category 5A and 5B, where you have asymptomatic direct or high-risk contact of lab-confirmed cases, like the family members of the positive cases. Now, these are all the family members because they fall under the definition of close contact. You must also know the close contact definition by now. We all know that 15 minutes within 3 feet, if you spend with a positive case, then you become a close contact. If you have spent in a close confined area within more than 2 hours, then you are also a close contact. So definition of close contact also was very difficult initially, but we finally got it from some abroad countries. But then we still don't have it defined as yet in India, but this is how we are following. So the asymptomatic healthcare worker in contact with a confirmed case without adequate protection is again Cat 5B. That's also to be tested. Cat 6, symptomatic influenza-like illness, which we are calling ILI. Then Cat 7 is pregnant women in labor. We must test. Category 8 is symptomatic. Again, going back to symptomatic, but these are all the not SARI but ILI cases among the returnees and migrants. Then category 9 is symptomatic influenza-like illnesses in hotspot or containment zones. And then, of course, there is a big category which is given as category 10 as other. So as a doctor or as hospital providers, basically these have to be defined by a doctor. The testing has to be prescribed by a doctor. then it can be in that preoperative cases. If you think that there is an asymptomatic case but coming from a containment zone, all that can be put into. Primarily, it is coming as pre-surgery or pre-operative or pre-procedure cases. We are putting it as other. Or if a doctor thinks that this patient needs to be treated and tested, then that can be in that category other. So this is how the categories are decided. Now, if you can ask me that who else can I test ourselves? If I want to test, can I do the testing? I would still say the number of testing facilities for us has gone up much more than what we started, but we still think that we should not do the testing just because we want to do the testing. It should be falling under the category, and that's how we should do the testing. That is all about who. And then if we come to the next set of things that then as I said, that any acute infection, we should do an RT-PCR or an antigen testing. Antigen testing hasn't yet started with us, but RT-PCR, yes. RT-PCR is the gold standard for identifying COVID-19 positivity. Of course, for seroprevalence or epidemiological survey, which has happened in our country, results are not yet out for public knowledge. Community spread or herd immunity, antibody testing is preferred, easy to perform on a group of patients. There less expertise is necessary, less expensive. I'll talk about a little more about the about the antibody testing. Now, so that is the third point where we need to talk about that. What are these testings? As Mr. Barua mentioned, that RT-PCR is about, there are two types. Open platform RT-PCR, where you have to have step 1, 2, 3. It takes about 5-6 hours to go through those steps because we actually separate the RNA through different kinds of fluids and then get into the virus DNA. Viral DNA is being isolated, and through different steps we go into detect the range of virus particles, and we decide on positive and negative, and come to that CT value. CT value is 10 to 20, it is positive. About 30 to 40, it becomes a little question mark, but below 40, they've kept it at CT value for positivity. More than 40 CT value, it becomes negative. So that's the open platform RT-PCR, where your biosafety levels are also at 2B, but there's still this viral, because you are separating the RNA, it becomes a little difficult for, you need more PPEs, more protective gears, and it is a little more difficult than the closed system, where you have actually, it's all cartridge made and ready made. And those are all closed systems, do have the samples. You have to put the sample. As you know, the collection is nasopharyngeal and oropharyngeal swab through circulating a particular way. You have to take the swab. The repeat tests happen if we don't take the swab well. So we particularly have to be trained who taking the swabs. The doctors, normally we do, the junior doctors, and some of the very senior nurses can also do, but we are trying to do it with the doctors, the senior registrar kind of, that JMS category, but they have been trained how to do the swab testing by the microbiologist. And then if you put the sample inside the cartridge for a closed system and put the sample inside the machine, then the machine automatically decides and then comes back with the checks and quality control methods and all that, the positive and the negative value. Now this can be done one cartridge at a time. So you can only, your machine can have 4 channels. Normally it can be more also. There are newer versions are coming up. The available machines for us was about 4 channels, but now there are new machines that are coming up with more and more channels so that you can do more and more cartridge and closed test. Closed tests are more safer for the healthcare workers than the open RNA extraction testing. So the open testings are also in large quantity. You can do 48 to 96 numbers. Closed system is always one after another, but then for open platform system, you need batches. Here you don't need the batches. You can just keep on doing as it comes. So that's how the types of RT-PCR platforms that we have. I think there are many types of machines are coming in, and all our hospitals are slowly gearing up to do the testing facilities, as Mr. Barua was saying, and which is good. We started off with about 1,000 to 1,500 tests in our state in the beginning of about two months back, but now we are doing almost close to 9,000 to 10,000 testings a day, which is, I think, is very valuable, because it actually it has reduced the certain parameters better. It has made the parameters better, and we are now at a better mortality and morbidity area. Now, the only other thing I need to talk about is the antigen, antibody testing. why should we do antibody testing, and what is this antibody all about? Whenever you have an infection, that works as an antigen. The virus is the antigen, and the body actually responds this by creating immunoglobulins, which are initially the first 7 days to 14 days. It is that IgM category, and then after 3 weeks till the lifelong, there will be IgG category, the immunoglobulin G category, and you have to. The antibody tests actually defines this antibody. The moment you have the antibody IgG or IgM, then you would know that you have some immunity within you. So if you have 50% of your population, if they do have antibodies, then IgG antibody, then that there is subclinical infection inside the community, and they are immune to have new infections, and naturally we call that herd immunity is achieved. So that's a good thing for a community to happen, because then you are protected to the newer infections. The patients who are already infected have got the antibody with them already, because they are already infected, so they have their antibody. We really do not know, like some of the diseases where we know, say for example chickenpox, if it happens once, then you have the antibodies within you. The chickenpox will never happen to you second time in your life. For this case, we really do not know as yet that the lifelong will be the immunity, or how long the immunity will be. But there is a certain kind of immunity we know. There will be immunity. So we are waiting for a good survey to be done on the seropositivity and the rapid antibody testing, which should be done, which has been done. We have heard that it's been done. ICMR has done a survey. I think the survey is not on a very large section of population. I think it is about 30,000, as we have heard. It is not yet out for public usage, as I said before. So if that happens, and that talks about a certain amount of infectivity ranges. It talks about a certain amount. So once we know the results of that survey, or we can do more surveys, then we will be able to know that whether we have the subclinical infection and whether it's immune for the virus, and that's a good thing to happen. And over the moment you have more of these infections, subclinical infections, you are more immune with antibodies. You also the infectivity of the virus also comes down. So even if it infects you, the viral loads will be lower, the virulence will be lower, so morbidity will be lower, and mortality will be lower. So it will be better disease to handle. So that's how I think. And over and above, we have to. With this antigenic determinant, we are working on the vaccine, creating a vaccine, which is actually an antigen which is given to the body to create the IgM initially and IgG later. And that is what is happening all over the world. There are a lot of researches are happening, and manufacturers are working on creating a vaccine. We will soon get a vaccine to protect ourselves from this infectious disease, like all other diseases we have done in the past. So I think this is how I will talk about the testing facilities, as Prashant wanted to talk about, and then let's do the testing for the right people, and let's have judicious way of doing testing, and let's manage our patients better in the days to come. Over to you, Prashant.
Thank you, Rupalidi. Very comprehensively, you have covered the entire topic. There are a lot of questions regarding in people's mind, because amongst our 160 participants, we have many non-clinical oriented people as well. I'm sure there are many questions which will come back to you later towards the end of the program. Thanks a lot once again. Now, the next topic in our list is regarding government and private partnership. And the designated speaker for this is myself. So I will try to squeeze this in and try and manage some time. So we'll go at a slightly faster pace. So let me just give you a few figures before we start. This is a comparison between the expenditure in defense and the expenditure in health. This is not from any white paper. This is from data available across Google, and I've just pulled across a few numbers just to understand where we stand. USA spends about $650 billion on defense and about $3,600 billion on healthcare, which means it spends 6 times the amount on healthcare which it does on defense. UK spends about $40 billion on defense and about $200 billion on healthcare. The UK spends about 5 times the amount on healthcare than it does on defense. Let's take a slightly more eastern cousin. Let's consider a country like Thailand. Thailand, the spend on defense is about $6 billion, and the spend on healthcare is about $25 billion. So a country like Thailand with a lesser GDP and lesser HDI spends about 4 times the amount on healthcare than it does on defense. Now, we in India, we have an inverse ratio. Our spend on defense is about 4 lakh crores. Our spend on healthcare is about 70,000 crores. So we spend 1/5 on healthcare compared to what we spend on defense. Yes, we do have nasty neighbors, but we have an equally challenging healthcare scenario in our own country as well. Now, many numbers are there that we are spending 1.6% of GDP on healthcare and so on and so forth. Whatever be the number, whether it is 1.6 or 2.3 or slightly more than that, the fact is it is still a fraction of what we are spending on our defense budget. By this logic, if you go by the average of these countries, we have to make our healthcare spend at least 10 times of what it is right now, if not 8 times. It's not possible for the government alone to come and invest so much money in the healthcare space. Even if the government does increase its spend to twice or thrice the amount which it is doing right now, it has to do so in the areas which are more important and more immediate in nature. We are still not away from communicable diseases. We are still battling the primary diseases itself. The expenditure of the government will probably go more in the primary healthcare, in the rural settings. That is where private sector will probably not be interested in doing much work because it's very impossible. It's financially not viable. Private sector right now contributes to secondary, tertiary, and quaternary healthcare in a larger fashion. About 65%, 63.4% accurately, of our healthcare delivery happens through our private sector. Now, you see, there is a choice which government has to make. The choice is that what role does the government want to play? It can either choose to be a provider or it can choose to be an enabler. By being a provider, it has to physically deliver care by itself, which means have own hospitals, have own manpower force, and deliver the product yourself, deliver the service yourself. Or it can choose the model of being an enabler by way of being a paymaster, whether it is by an insurance scheme or by any other modalities. The more efficient countries who are delivering healthcare at a reasonable value are the ones wherein the government itself has never been the provider, or at the best has been a co-provider. There has to be an environment where the private sector has to be roped in. They have to bring in the much required infrastructure, the much required investment, and provide that service to a growing massive market, to a growing massive population, which demands and desires and deserves healthcare at the same time. Now, see, there's another aspect to it. There was a study done where an operation of gallbladder stone in AIIMS, Delhi, was costing about 4.3 lakhs. That's correct, 4.3 lakhs for a gallbladder stone operation. This is where they did a proper costing, took the entire infrastructure cost, the manpower cost, the capital cost, and then divided by the number of procedures. By comparison, private sector is doing CABG, cardiac bypass surgeries, for about 1.5 lakhs. The difference of cost is for us all to see in these numbers. If all organizations were to raise their own funding, then I do not know what will be the cost of healthcare delivery or institutional practices. We have many examples in front of us. We have many examples wherein government has been a provider. Look at steel companies. Steel Authority of India Limited is a government company. Performance of a sale versus a GSW is very, very different. The reason is not just pure inefficiency or anything like that. It's not the case. But wherein government becomes a provider, it has multiple responsibilities. It has HR responsibilities. It has more social responsibilities. Job of the government is to govern and administer the way the country is run. If it comes itself into businesses, then some part of that will automatically transpire into delivery of commercial activities. Similarly, if private sector was to run a government administration, that would never work because private sector has its own commerce as the basis of its thought process. We have many such examples. We have Air India, we have compared it with an Indigo if you like to, and there are many other examples. So All in all, there are many places where the government has actually come as an enabler, and that model has worked fantastically. If you look at the NHAI model, the Highway Authority of India model, where the government has enabled private sector to come in with large investments, they have come in with large numbers, and they have created a whole network of highways. They have created fantastic roadways. The speed which earlier was, let's say, 1.2 kilometers per unit has now gone to 4.3. It's not just because of governance, but it's because of the policies and the implementation of those policies. We require something dramatic like that in healthcare as well. Our tier one cities are the urban places are the place where only healthcare is available. Tier two and tier three cities, there's hardly any healthcare services available. Many models have been successful in these places. Take, for example, the Bengal government model of dialysis. In this model, the government provides the machinery, the equipment, the infrastructure, and the private operator only has to come and operate. We have set up about 3,200 dialysis machines in the state of West Bengal, and the cost of delivery is around 650 to 850 rupees. That model works fantastically because the rural population, which was never able to reach a dialysis center by itself, is now getting this service. We have seen similar models in imaging. In the current medical college hospitals, a lot of private imaging centers are there which use teleradiology and deliver maybe at one fraction of a cost which an outside independent player does because of sheer volumes. We have seen the new recent 42 super specialty hospitals which have been set up have also gone for a similar model. Now, that model also is very, very lucrative. The government has set up in collaboration with an OEM like a GE or a Philips or a Mindray or Siemens, and they have set up same equipment across all the hospitals. They have determined the amount which the private sector will charge. The bidding is on the basis of the concession which the private sector will get. So this is the reverse bid process. It's a very successful model, and once all these operations, these hospitals come into play, this is going to work fantastically. West Bengal government also had a very, very brilliant project by way of nursing colleges. They were to start 27 nursing colleges on a PPP model, where the government hospital would be the parent hospital, and the private sector would get the land adjacent or within the same complex, and they would set up a building on a 30-year basis, and the government would get the benefit of subsidized manpower, continuous supply of manpower, and the private sector would get the opportunity to build the college and have a parent hospital. This would have been a major game changer for West Bengal because this would have brought in 5,500 seats in nurses. Currently in Bengal, our number of seats in nursing is less than 4,500. We are behind Haryana also as regards nursing is concerned. With the recent exodus of the nurses from Northeast and South and other parts of the country, healthcare sector, especially private, suffered a knee-jerk reaction. For all reasons, for many reasons, we require a supply source of our own. This would have been a fantastic project. I'm sure this is still not shelved and somebody from the government will sometime or the other take it over. If this happens, within 2 years' time, we'll come out with excellent model by ourselves. Public-private partnership has seen many other successes as well. If you look at the model in Sweden, it's a roaring success. If you look at the model of NHS, where the rates are rationally discussed and fixed, and the private sector is willing to participate, they participate and they come out with decent numbers for themselves. We in India can easily emulate those models. We can come back, we can easily implement those models, which is going to be a win-win-win situation for the patients, for the providers, and for the government as well. Now, long before we have to take a decision as an economy, we have to take a call, we have to take a decision whether we are going to be a socialist economy or a communist economy or a capitalist economy. Communism and socialism has been tried by many countries far more powerful than us. Even the largest communist country right now has employed the model of capitalism. Private business is bound to function to survive on its own. If they do not produce or serve at an efficient cost, they will not be able to survive. They do not get grants, they do not get any funding. They have to earn their own bread and spend their own money. It's an efficient model by design. And I think long before we have chosen as an economy to be a capitalistic economy, there is a taboo regarding business, that business is evil, business is bad, ব্যবসা করছি, ধান্দা করছি. But it is business which provides for jobs, jobs which thousands of us go to often. It is business which provides the taxes which the country runs on, whether it is GST, whether it is direct tax or indirect tax. It is the generation from the business activity, the economic activity, based on which fuels our economy. So ethical business is not bad. Business is never, not always meant to be unethical. We have to overcome that mental block. Once we overcome that, once we decide to shake hands, once we are able to have ease of doing business, once we have mutual trust, and there can be situations where both buyer and seller gain. There's a win-win situation. And there are so many opportunities, especially in Bengal, with its own captive 10 crore population. With if you join the adjoining states, we get a population of about 20 crores, and the supply is extremely short. There is extremely high scope for this kind of a public-private partnership, wherein everybody stands to just only gain. We only have to figure out the right model. The intent has to be there, and the credibility of the deliverer has to be there. Everything else will be sorted out by itself. So I think going forward, this is something which can be looked into in a very positive fashion. We can set up a board, a trust, and have a nice way of mechanism of how we're going to handle this situation. But in order to bring in larger infrastructure, in order to bring in larger investment, in order to bring in quick and fast delivery, I think this is something which we should ideally look at in a very active way. Thank you very much. And now I would like to move to our next speaker, Simar. Simar is my friend from CMRI. Simar, in this current scenario, supply has been a very, very major issue, whether it is PPE, or whether it is testing kits, or whether it is even your basic protection equipment like masks and gloves. But supply, not just for now, but in the future, how can you serve the population without having a proper supply base, a robust supply management system? And you have been at the helm of affairs for a number of reputed organizations. We would love to hear from you regarding this topic.
Thanks, Abhishek. Thanks, Prashant. Abhishek, would you be able to play those couple of slides I sent across?
Sure, sir. Just a second.
So it's an interesting topic and an interesting subject to be speaking on. On the 23rd of March, when the whole country went down into a lockdown, we obviously all of us started doing our mitigation meetings. What are the possible scenarios, financial, safety of employees and safety of patients coming in, supply chain, and a host of other things were a part of our agenda in our daily conversations. Ironically, we spent the maximum amount of time tackling the supply chain bit of it, because this was something which was an external factor we did not have a control on. I mean, there was a lockdown. You did not have a control on the transportation bit. You did not have a control on, the manufacturing part. So that worried us a lot. Nobody had a clue how many patients would come in, how soon the hospital would get filled up with COVID and all of that. So while this situation, obviously all of us have seen a situation where we bought a PPE for 3,000 rupees and now it's also available for 250 rupees. So we've seen all of those. But as an organization, it helped us identify four key areas and improvise on them. And when we move into normal times, I am sure it would have been a learning as far as our supply chain management is concerned. So while during those days we did stock up a lot of stuff wherever we could get, whatever price we were getting it. The single mandate was just to hold, not anymore. I mean, a couple of weeks down the line, once sense prevailed, we obviously started working in a much structured and a much data-driven way. So I put these things into four different buckets. Could you move to the next slide, Abhishek? One is, you have to have a process-oriented supply chain. Data-driven inventory management is the next one. A good relationship with all your vendors and optimal procurement costs, which is obviously one of the important parameters. So moving to the process-oriented supply chain. Next one, please. Next, Abhishek, next slide. Yeah. So when we say a process oriented supply chain, most of our organizations do have a system where we have a fairly decent process oriented systems, but we realize the importance of data, data which ended up your ability, which basically led to your ability to make sensible decisions. So we as an organization are moving the needle towards having a data-driven decision-making system, continuously keep on re-engineering business processes. Now it could be as soon, fast as, let's say, a weekly basis, because of the situation being so dynamic. Um, Ultimately, the aim remains to save costs, time, and you're obviously up to date with the best policies. So, and or integrated cash happens to be the king right now. So, in terms of the pay systems, what are the way we pay, how can we defer? So all of that we also try to put into place. Now there cannot be a real rule book for the entire industry, but every organization would have its own ways and means. But I think it helps to have this particular system in place. And as I mean, this is again a bit of a utopian situation, but adopt technology for paperless transactions to an extent as much as possible we could. So we are, I would not say we kind of achieved this, but it's WIP, work in progress, where everything on the supply chain front is going to go move towards a very process driven system. Next is the data driven inventory management. So our inventory, we've all kind of kept and Abhishek, next slide. We've all kept an eye on our inventory days. Once we start looking into the nuances of your inventory, from the smallest and the largest item, and again, from a data perspective, I think your efficiency increases leaps and bounds. So number like we need to, the demand forecasting is important. To just give you an odd example, there are certain high cost catheters which keep on lying in the cath labs for months and months together, rather years, some balloons, which jack up your inventory demand, which have so inventory time, which have blocked a lot of cash. So all of that we've moved towards on real time data, and forecasting errors. Again, you could have some sort of clarity on that, and any surge in demand one has to be prepared for, not by stocking but by having the vendor management system, which is much more better than what we currently follow. We also we minimized inventory holding periods. I mean, right, while we saw a fair bit of a spike in April and a part of May, but we're getting back to normal. But I'm confident that when we go back to normal times, we would have reduced our inventory time by at least 4 or 5 days from the previous times, just by getting into this systematic way of functioning, and revisit the formulary. So we've, as a principle, we have twice a year. One is 1st April, where we do the entire formulary is approved at the beginning of the financial year, and secondly, 1st October is the second or a smaller recheck of the formulary where it gets revisited, so that you are in a position to keep on shedding flab and just carry on with the muscle going every 6 months. Next, please. So the third is, needless to say, optimize procurement costs. This is there are multiple ways to do it. It could be, single negotiations. In negotiations, what we've seen is that the more the muscle you show in terms of your combined strength as a hospital group, your ability to buy a much bigger chunk, you get a better deal. And if you are a standalone hospitals, you can form a couple of, or rather, let's say 8 or 10 standalone hospitals go ahead and form a group. Consolidate distributors, you get better margins and better credit terms. And also, most of our hospitals, we see these expensive equipments ranging from CTs, MRIs, cath labs. The kind of money we spend on CMC is humongous. And if we actually got down to doing the project in terms of, let's say, hypothetically, if we did not have these AMCs and CMCs, what would be the cost if we were to foot the bill ourselves? I mean, there was a substantial chunk of saving. So we would recommend converting CMCs to AMC. I mean, I would not say this should be a reckless exercise where we do everything in one go, but a judicious move from CMCs to AMCs and convert AMCs to in-house maintenance. We've also negotiated with some vendors in terms of extending our AMCs, which were expiring on the 31st of March till the 30th of June without any extra cost. So that's also saved a little bit of money. And once we sit with them for the balance part of the year, that's the next 9 months, we'll probably convert some of the CMCs to AMCs. So there is some money lying on the table on that. Next, please. And finally, by the end of it, a healthy vendor relationship really matters. Ultimately, it's a very people-driven industry or a people-driven business. So once you've established your proper vendors through a rigorous selection process, then you engage long-term with them. Build long-term partnership, encourage constructive competition among the vendors. And you got to also at times put yourselves in their shoes. So, and it's something, and we can always arrive at a win-win arrangement. And always have a backup plan in a situation like this. I mean, my biggest worry used to be not like this during these COVID months, not certain consumables or drugs, but things like oxygen. What I mean, I don't know how many hospitals in Calcutta have oxygen generators in their premises, but we were like, medicines and all, we can still borrow from someone, we can manage somehow. Let's say the oxygen supply was too big, and we could, if something, God forbid, something was to go wrong with a patient because of lack of oxygen, I mean, that would be catastrophic. So have a backup plan. Have a backup plan of whatever is possible. Go for a scenario planning where we think out of the box. So this is all what we did in the last few weeks. Some interesting observations came out, and we must also, most importantly, that's the last slide, Murphy's Law, we must remember. And longer chains have more links and higher chances of breakage and entanglement. So we should all move to technology. Let the dependence on manual intervention reduce, and technology is available now. Technology can bring great efficiency on the table, and as organizations doing such sensitive stuff, we must move towards technology. And by the end of it, human relationships are of paramount importance. There's nothing above them. And a call to one of the vendors or something works like nothing else. So that's my 2 bits of learning on supply chain over these last 2 odd months. And let's see how it goes. I think we should come out as an improved organization on this front, I'm for sure.
Thank you, Simon. It was you put the Murphy's Law absolutely in the right place. Healthcare is a garden of Murphy's Law. I think we face it on a normal
That's
basis.
right. Healthcare is a garden, and the entire Murphy's Law is now landed upon our head.
So everything that can go wrong will go wrong. That is the premise which we should
Absolutely.
take. That brings us to the expertise of our next speaker, Mr. Venkatesh, who is going to tell us how to handle operational issues regarding leadership, administration, especially during these VUCA times, and also in the process of rebooting healthcare post-COVID. Over to you, Venkatesh.
Thanks, Prashant. A very good evening to all our distinguished speakers and audience. Now, when we talk about rebooting healthcare, it is more about reimagining healthcare post-COVID. It's very clear that nobody has any experience in handling these situations. People might have theoretical knowledge of pandemics, but this is the first time the current society is having a problem of this scale. But it is equally important to try and learn as much as possible about the disease and mitigation plan. So the primary focus area, there are several focus areas when you talk about rebooting healthcare, but I would focus on 4 primary focus areas. One is safety and security of staff. The second is safety and security of patients, who are our ultimate warriors. Operational efficiency or the lean management for future. Cost management, viability, and cash flows. We have discussed, and I am sure most of our healthcare providers are following the safety and security of staffs and patient measures for the last 3 months. When we talk about safety and security of staff, which is our frontline warriors, safety at work, which is ensuring adequate protective gears appropriate for the area of work, which is available to all the staff. Second is educating and training them about the COVID and the prevention modalities. Third is good practices, which everyone is following, that is hand washing, social distancing, workplace disinfections to be encouraged, having robust SOPs in place with easy access. Committees have to be formulated to implement and monitor safe practices. And then providing adequate support to staff to attend to the physical and mental health needs, which is the need of the hour at this stage, and it has to be absolutely focused on. They should be given the right to refuse treating patients if they're not given adequate protection. We have to give them that right. If we take care of them, they would actually take care of the patients fearlessly. Then we talk about safety and security of patients. Biggest warriors, they come to us with blind faith. We need to take care of them and make the hospital safe for them to avail the care they need. Most of us are doing that. To take care of them, we have segregated COVID and non-COVID patients. Bigger hospitals with privilege of more than one building, they have separate blocks for COVID, non-COVID. Other units who don't have this privilege may have separate floor for COVID suspected patients. Patients stated for surgery should be first tested on OPD basis before admission. On being tested negative, they are shifted into the green zone or the non-COVID building. Patients needing emergency admissions should also be admitted into a holding area. Tests should be done. Once they are reported negative, they are cohorted to the specialty in the green zone. So what we all are trying to ensure is a green zone is basically the area where patients feel extremely safe and away from the risk of infection. So facility planning plays a very important role for safety of patients and staff. Older or high volume facilities will face a little bit of difficulties in making these significant changes. So their focus should be more on operational streamlining. We'll come to that. Newer facilities or hospitals with lower volumes can make necessary adjustments to ensure minimal entry points, segregated screening areas, sufficient waiting space. Doctors' chambers should be remodeled to ensure that OPD asymptomatic carriers do not cause transmission, either to the doctors or subsequent patients. There are glass protections or plastic sheet protections, which most of the hospitals are trying to implement, which can be sanitized on a regular basis for a distancing and protection. Then front office management would also need to be looked at, minimize touch points for the patients. See, what happens is, again, as Simar was saying, finally, incorporation of technology actually helps in minimizing patient movements within the system and reduce risk. We'll come to that again on the lean management thing. Now, you see, when we talk about operational efficiency and lean management, survival is the main focus for this year. In healthcare, the patient flow is only going to be deferred. It's not going to be lost unless there is a radical change in the patient behavior. They will also gain some market share. See, there will be few organized players standing in future, and they will get some market shares from the smaller players. Whatever we can do today it cannot be immediate, but it would be over a period of time. Now, when we talk about short term, money is going to disappear, and we are not going back to pre-COVID numbers in the near future, but cost will keep on increasing. So it's important for us to have a lean management system. When we talk about essential services in healthcare, we generally relate to those healthcare workers who basically are touching the patient while giving care, which is a doctor or a nurse or a paramedic staff. Now it needs to extend to food providers and cleaners as well. Except a few frontline support staffs like the billing counters or in floors, the floor coordinators, the rest of them are termed as back-end workers, should practice work from home. For bigger chain of hospitals, in terms of back office, fewer units should be looking at serving the whole group. We should look at more centralization of back-end manpower. Smaller hospitals should look at outsourcing payrolls, compliance, collection of outstandings of payments and taxations.
Venkatesh, we lost your audio. Can you check your mic? Venkatesh, can you check your mic? We lost your audio. We can't hear you, Venkatesh. Can you check your mic, please? It shows that you are not on mute. Can you hear me? Can you hear me? Yes, you're mute now. Okay.
Prashant, am I audible?
Yes, now much better. You can go ahead, please.
Yeah. So when we talk about nurses, there are certain categories of nurses we've already discussed. So we have nurse, a ward in charge, maybe a floor in charge, nursing managers. These nursing managers are the ones who should fall into the ambit of work from home concept. They are used to do job of data entry of vital patient parameters, requisitioning their investigations, medicine, so on and so forth. And they are not in direct care of it. Sections along with the nursing managers are the ones who should be following the work from home concept. If this nurse say from home, and I'm going to take care of your history, I'm taking your history, it is more impactful than Miss Sujata doing this. So a nurse who can actually do a bigger contribution staying at home should be looked at. You see, the payout should also be based on the number of patients seen and tracked by them. Conventional marketing practices will give way to digital marketing. Scalability and traceability of digital marketing efforts will definitely supplement the cost benefit it carries. Now, more important is we need to focus on bolstering technology such as appointment management system. All patients in the OPDs should be mandatorily booked through an appointment management system. Online payments at the time of appointment booking will minimize the queues in the OPD counters or the cash counters. Lesser waiting time of the patients in hospitals will minimize the risk of contracting infection. Lesser queuing also results in minimal staff to man the place. Doctors should also ensure that the appointment obligations are fulfilled within stipulated time. You see, the use of EMR and digital prescriptions in OPDs will minimize the need for paper handling. It can be pulled out from any of the counters. Order for labs and diagnostics should also be automated through the HIS and will not require manual entry by chloric systems. Technology plays a very important role for future when we talk about rebooting. You see, we need to focus as healthcare workers or healthcare industry on patient apps for accessing the prescriptions and lab reports, which this need to be designed on immediate basis. You see, Once that happens, it will reduce further waiting times and queues in front of report delivery counters. Who knows, maybe a report delivery counter may not be needed in future course of time. These are also very important for medical management of patients like diabetes management, etc. Follow-up consultations should also be encouraged via video consultations, as all these reports and investigations are digitally available and the patient need not be seen physically once again in such short intervals. Similarly, admission and discharge processes would also be readily available via EMR, hence minimizing the paperwork formalities and waiting times. I just wanted to give an example or an idea of what we are also doing. We are building up a platform in collaboration with Microsoft, whereby a mobile app is being worked out both for patients, which we just spoke about, and for the doctors for monitoring, remote monitoring of patients. These would be available both in iOS and Android PlayStations. When a patient is admitted through our HIS under a team of doctors, the EMR records of each patient is readily accessible through this app on the phone of the primary consultant as well as the rest of the treating team. Each active patient pops up as a group similar to a WhatsApp group, and the entire treating team is a member of the group. Lab reports and radiology images are automatically pulled into this group from the lab information system and the radiology information system after they're certified and released. So there is a zero delay in accessing these reports and eliminating intermediaries of care for the same. We talk about lean management again. We should also work in developing eICUs, whereby monitoring patients can be live accessed on the the doctor's mobile phone. Billing software also will directly interact with EMRs of the patients, so there is no delay in billing procedures. This automation speeds up the discharge process and eliminates the risk and increases transparency of billing. All these not only help in increasing the quality of services, but minimizes the manual work you need to service the patients. You see, it is very clear that operational efficiencies is dependent on development of technology. It can be scaled up rapidly and with least marginal costs. Technology plays a very important role. When we come to the last topic, which is cost management, viability, and cash flows, many hospitals have already exercised every little option to reduce their variable costs. That leaves us with semi-variable and fixed costs that need to be addressed. Hospitals have to recover from this phase. We would have to rework on how recruitments have to be made, more on a multitasking model, and also modify performance goals and incentives based on the new goals of the organization. Middle-level employees should also fall into a performance-based incentive system as a part of structured payout, so that they are also aligned to the organizational goals, both short-term and long-term. For senior team members across all sections of the hospital, the payout should be temporarily based on equitable weightage of organizational performance and assurance model. We should all be a part of the organization and support the same during tougher times. Model can be revoked once you near your normalcy. Since the capacity to pay reduces and more emphasis would be on cashless schemes with lower realizations, eventual payout should factor the same as well. We should focus more on consolidation than on expansions as far as our plans for expansions or capex infusions are concerned. Long-term projects, except if strategically concluded, should not be explored into. There should be an element of conservatism on long-term projects, but short-term, medium-term calls can be taken. At this stage, EBITDA is not the focus. Loss containment and cash flows are the priority. Having said that, we should also learn to adopt quickly from a worst phase to a bad phase and eventually to a good one, which means it is not purely about control, but to learn the art of opening your purse for future returns in a conservative manner. Internal audit team should be more focused on treasury and cash management at this stage. Now, when it comes to infusion of capex, by going by the previous version which I said, capex for this period should be purely on absolute value add in terms of investments rather than investments where you demonstrate the might of a quaternary care center. This will prevent overexposure to debts. When there is lesser exposure to debts, the debt equity ratio of a company may not get grossly distorted, but impact heavily on the debt EBITDA ratio, EBITDA being obviously on the negative side as we have gone through tough times now. The risks of what debt EBITDA ratios skewing is, it could lead to a breach of covenants when you talk about the angle of lending institutions, which could hike the interest rates and leverage on it to minimize the risks. But every analyst would look into this ratio only on FY22 and 23 and not on 21. So hopefully we should be out of that risk. Once you're able to survive at this particular stage for this whole year and consolidate from the next year onwards, situation should be different. A few of these measures are short term, few of these measures you can carry on with us for a longer period of time. But our current objective being survival for this year, once we ensure that everything falls in place, we can come back strongly in the near future. Thanks, Prashant. That is what I have right now.
You've spoken like a true financier. And like every organization, finances is the pulse of the organization. And I would love to implore you more about how you're talking about share from smaller players and on the debt EBITDA, which means the ICI interest coverage ratio aspect. I would love to discuss more on that, but in the interest of time, I'll have to skip that. Probably we'll have to take it offline some of the time.
Sure.
Our next speaker is Ms. Richa Singh Devgupta. Richa is representing Fortis Healthcare, and Richa will be talking to us on a more positive note about more optimistic future of healthcare, which means new projects, new investments, and establishing new projects. Richa, go ahead, please.
Thank you, Prashant. Thank you so much. Can I request Abhishek to put up my presentation? Yes. So first and foremost, I think it has been an absolute pleasure to be here and hearing all the word of wisdom, which I can clearly see is coming from the experiences all my co-panelists have. And not to undermine the viewers or listeners, so I can see that most of the people who joined in have continued to be with us and very patiently waiting for their turn to ask some questions. So I think after me, I'm the second last. So what I have done is I have got quick 3 slides, which I'll take you through, and I'll speak more from my experience, operational experience, putting it in project form, and that's about it. So if you can just move on to the next slide. Okay, now Indian healthcare, while our topic says that, rebooting healthcare setup post-COVID-19, I'm a firm believer, and I think none of us would disagree, that this rebooting has been required for a long, long time. So COVID or no COVID, I think we needed that. So when I say so, it is about giving due importance to primary and secondary healthcare. Because while from our college days, it's taught that, your primary healthcare should be the base of the pyramid and should be the broadest, but I don't think that's the reality on the ground. And if we have something, you can look at that picture, that's what it looks like. And if I tell you that COVID-19, primarily it can be treated at primary and secondary level hospitals. And one reason that most of the hospitals, tertiary care and quaternary care hospitals are getting overwhelmed because we really do not have a strong primary and secondary healthcare. So when we talk about project going forward, post-COVID, I think that's one thing. Not only government, I think as private sector player as well is something which we really need to pay attention to. Well, now, second thing, a question is repeatedly being asked that, pandemic, especially COVID, looks like is here to stay. And it's not while the earlier one was 100 years back, but it's not that we would have a 100-year gap before we probably get the next one. So should we have projects which is dedicated to these kind of pandemics, or should we kind of, have repurposed hospital? So my vote goes to that we should have repurposing of existing infrastructure. What I mean by that is that you should have a capability of expand your services, modify your services in the existing hospitals rather than creating large hospitals which are meant only for infectious disease. So that's where I stand in my opinion. Now, when we plan the hospital, I think somewhere largely I have seen that I have actually seen some of the hospitals which doesn't even have a concept of isolation room. Right. So when you're designing a hospital, when you're planning a hospital, it becomes very, very important that infection control team is consulted. They are the people who can exactly tell you, depending upon specialty you're going for, depending upon their foresight that how things actually happens in the hospital, they can tell you what are the number of isolation room and so on and so forth that you need to have. And in project, we spend crores and crores of rupees. My humble submission to all of you would be that whatever scale of hospital you create, whether it's primary, secondary, and tertiary, please focus on your manpower. And when I say focus on manpower, it is take good care of them. Somewhere, I think Venkatesh laid a lot of emphasis on that you really need to take care of your people, their safety, their health, their families' health, giving them assurance, giving them insurance, so that when they fall sick, it doesn't kind of really hit their pocket. So all of that you need to do. It's just that saying that you're heroes really doesn't work. Next slide, please. If you're going backward, can we go forward, please? Next one. Yes, you can hold it here. Now, what I have done is there are like 6-7 pillars around that. You can actually look at the hospital design, and the points that I have mentioned would apply to existing hospital as well as in case if you're creating a new hospital. So first and foremost is flexibility in design. It goes on to say that, as I told you, that see, today when I walk around the hospital, and if there is a need which is felt that we require more critical care bed, fortunately the design is such I can actually convert some of the single rooms into ICU rooms or critical care rooms. So that flexibility in designing the hospital must be there. And when you browse through a lot of information, how some of the countries abroad have handled this epidemic or pandemic is there are places like their basement actually converts into a large dormitory kind of a place where you can put beds and you can treat patients. So, and it doesn't take much to have those kind of flexibility in your hospital design. Things like wider corridor. These are the things which you need to keep in mind and have that flexibility in your designing. Patient care areas and sitting space. When you're talking about that, see, if you have a large lobby with sitting space, which many of the hospitals have that, in current social distancing practice, it is becoming increasingly difficult to keep a lot of people in one single room. You would have realized that with 50% of your OPD numbers, we are actually getting overwhelmed that how do we maintain social distancing. In that case, I think it makes much more sense to have separate OPDs and separate waiting areas for the patient. It helps you segregate the patients in different areas, right? And coming on to the third one, which is antibacterial material. When you are constructing anything, you need to have material. So I was talking to one of my infection control team member, and they said that anything which cannot be cleaned or washed should not be used in the hospital. It's as simple as that, and pretty simple to understand. Now, antibacterial material we need to use in elevator, doorknobs, handrails, and everywhere, including your floorings. And it is seen that if you have copper knobs, those are the best one to be used because it has the antimicrobial properties. Now, looking at air conditioning, see, now when we're looking at it, we are rather fortunate that it's not an airborne disease, because I don't think we really have a huge number of negative rooms across our city. But what is helpful is if we have a separate AHU handling units, right, air handling units. So if you have separate AHU, you can segregate areas, you can take a patient there. I know that there's some hospitals in the city who have not been able to take patients because of these constrained old designs and so on and so forth. So I think that comes very, very handy when you're designing your hospital. There has to be ventilation. Ventilation not necessarily means that you have to have all the rooms, corridors, open areas, air conditioned. Open area, when I say, I mean to say the waiting areas and things like that. But you could also have well ventilated open window concept, which also helps you save cost, because one of the highest electric consumption is in your air condition, and 2.5 to 3% of your total revenue actually goes into electricity. So that's one area which one must look at it. Something which is going to be very popular is the touch-free control. Touch-free control, when we talk about, it's largely around, you could have lighting, temperature control, and sensor-based tap, which let people use things free of their hand, and there's no touching there. Then we're talking about OPD rooms. I think all of us are in consensus that telemedicine is one big savior during this time. And going forward, if it is possible, each of these OPD consult rooms should have video conferencing facility. It doesn't have to be a very fancy one. You could have a very basic one wherein your patient can sit and at least the follow-up calls can be done with the patients through these video conferencing. So that's about the hospital design which I have put together. We can move to the next slide, please. Now, I think Simar touched upon it, Venkatesh spoke about it, is the technology. Technology, as I said, that not only telemedicine, I think technology at large, whether we talk about EICU, whether we talk about robots, whether we talk about, again, connecting with our people. So this is something which has really, really helped us. And here we are talking about automation and robotic for care and ancillary services. A lot of hospitals in India are also using that. Remote healthcare delivery, this is where we spoke about the telehealth. Then we're talking about cloud-based interoperable electronic health record, so that wherever you are, you're able to access your health record, and also it's easier to retrieve for doctor when you're doing a teleconsult. Then we're talking about artificial intelligence to enhance patient experience. This is something which has been very, very popular. It has, this facility is available on our website. In some of our hospitals, we have installed a robo, wherein you are completely touch free and you don't come in contact with people to maintain the social distancing. So these are some of the things I have been just able to put together due to constraint of time. But this is how the world is going to change, not only post-COVID, during COVID. So that's all I have, Prashant, and that's about it from my side.
Thanks, Raja. Great positive ideas and tech-enabled, but more importantly, very simple, like copper knobs. When we think about it, it's a one-time cost. If you look at the ancient constructions, we used to have copper knobs. Only now, because of the
Absolutely.
away from it. But it's a very important point what you raise as investment in primary healthcare. I would love to talk with you offline regarding that model, because contrary to, I believe that's a very different model which you have recommended. Thanks. We are running pretty short of time and a little late. Now let's quickly move on to Animesh. Animesh, you want to talk about telehealth and the modalities of telehealth?
Yeah, Mr. Prashant, surely I will be able to talk. Before that, because of the bandwidth issue, I'm not switching on the video, but I will be just showing you certain slides on this. Again, if the slides are visible, just let me know.
Yes, we can see that. You can go ahead, please.
Yeah. So when we
lost the visual, we can't see it now.
It's gone?
No, can't see it.
Is it okay now?
No. Abhishek, do you have animation slide? Can you upload those?
I don't think this slide he will be having. Just let me once again give it. Or just let me share it over the voice only. So telehealth is basically something between the demand and the need. It is bridging on the something on the demand on the need. Today, if you see, there is a bed demand of around what you call, by 2020 end, the bed demands and the gap will be around 50%. So for every aspirant requirement for any patient, half of them will get a bed and half of them will die without a bed. If I talk about the intensivist demand in the market, presently active intensivist in all over India, we have only 750, where the requirement is more than 20,000. So, and if I talk about the nursing demand, is 1.81 million nurses presently, registered nurses that we are having in India, but demand again is 2.82. So there will be a big shortage between the demand and the delivery. So this is where the telehealth is going to play a major role. And in COVID situation, this is even more true. Like Richa madam was showing that in US, the telehealth or e-health facilities have increased almost 3,000% post-COVID. So this is true in India also, Indian perspective also. We are most of the time we are approaching telehealth as a modality. If I talk about how it operates, like there are 2-3 models here. Telemedicine, all of us, we know that what telemedicines are and what was the fate of telemedicine. Now the telemedicine has become something advanced, like tele ICU or e-ICU, what others were talking about. So this is nothing but integrating all your equipments. Like if you have a patient monitor, if you have a ventilator, if you have syringe infusion pumps and other devices in your hospital, you can integrate all that and digitize those data. Because all of a sudden, what happens if your data is all on paper, those cannot be accessed from everywhere. Okay, so yeah, hope I am audible to all of you. Yeah. So this entire data comes into a single server, and from that single server, people can access. And this data can be accessed from anywhere actually. So physical rounds to the ICU, physical rounds to the wards or different places will be reduced with the help of telehealth. And this is mostly popular, and hospitals like Fortis, NH have already started their operation regarding this. In fact, Apollo has also started this EICU concept very well. And a lot of companies, alongside Mindray also, we are planning to launch this kind of facilities, and we are working on it. And definitely we'll be coming up with this kind of modality very soon. Yeah, any specific questions on telehealth, I would be happy to.
We have a lot of questions coming in, but generally we are over time, so we have already post 8 p.m. If the speakers are not getting too late, because I see all of them are still in office, so if they are not getting too late, I have a lot of questions. So either what we have the participants mail those questions, them answered on an individual in. Will that work, Abhishek? Is that all right?
So we can take questions, no issues. If it is okay with the speakers.
Right. So our first question is from Miss Miss. Present number of COVID positive cases is just the tip of the iceberg. How do we tackle the situation when this spike hits us the maximum? So I don't know, maybe Venkatesh, would you like to take this, or would Rupert Double like to take this? Venkatesh?
Screen freeze होएगा.
Prashant, could you repeat the question, please?
Sure. Presently, number of COVID positive cases is just the tip of the iceberg. How will we tackle the situation when there will be a spike of patients on a more community transmission level, since there's a limit of infrastructure and technology? So basically, how are we going to handle the peak?
Right.
Which I want to take this.
There's a lot of disturbance coming in.
Rupali, you take this one.
Okay. You want me to take this, Prashant?
Yeah, please go ahead.
Okay.
Well, you
Rupali,
seem to have
go
a good.
ahead.
Rupali, please go ahead. How do we tackle the peak?
Okay, so I think the peak is talking about the larger number of active cases for our country. We talk about very specifically for our country. We have to go state-wise and have to look at how the states are happening, because our country is very large, and we have to deal with peak of diseases in our region-wise. So if we can, because we are talking about Eastern region and today in Kolkata, let me talk about the how do we take the peak in Calcutta. Now we have already the disease is here for last 3 months, and we know that the active cases are increasing. But some days it is increasing, so there might be a peak, and we have to calculate. So we have currently we have about 17,000 beds in our state, and our current active cases are about 5,500 or so. So even if it goes very high, I don't think that exponential growth is which we thought that from 1 to 2 and then 2 to 4, and that exponential growth which was supposed to happen before the lockdown is not going to happen now, because with the lockdown we have actually controlled that geometric progression. So it is now happening in a kind of arithmetic progression. It is increasing, but also we have got very high recovery rate, which is close to 50%, and we have very low mortality, which is 3%, and we have very low sickness. The morbidity of the diseased patients are also very low compared to the other. So I don't think that even if there is a peak, we should be able to handle, because a large number of patients will be handled, the mild and moderate will be handled at homes, and we have enough capacity for our state to take care of the peak.
Great. So no reason to panic there. I'm sure the audience must have been satisfied with that. Richard, the next one is for you. The question is, what is the scope of new green and brownfield projects in East?
I think more the merrier is what I would say, because you're talking about specifically East, and we are pretty much aware that not only in East, across the country, I think number of beds are abysmally low, and we need to add more and more beds. Hence, yes, there is a huge scope. Due to, I think, certain reasons, people were holding it back for a time. But I think, with the investment coming in from PE and venture capitalists, I think people should open up more beds if they wish to do so.
Great. Thanks, Richard. Thanks for the positive note. Any other questions, Abhishek? A lot of physicians. Let me take this one. I think Richa or maybe from Animesh, you can answer. What is the role of remote patient monitoring in this scenario?
Animesh, you want to take it?
Yeah, madam, I can take it.
Please go ahead.
Remote patient monitoring is very vital in this situation, because it becomes almost touchless. So all your doctors can actually give virtual rounds to the hospital, to the ICU, and critical care areas and non-critical care areas. So the spread of viral infection will be less, as the physical touch will be less, and we can also digitize all the data, and we can draw up some kind of trend how the disease is moving in what direction. Presently what we have is all on paper, so if you keep everything on paper, you will not be able to draw a trend and set a trend and accordingly react. So with the digitization of the data, I think we can have more trends of treatment, as well as a touchless treatment.
I think we lost you.
Yeah, over to you, ma'am.
Yeah, so one thing which I would like to add is, I think, see, whenever we have looked at the major challenges in healthcare, accessibility has always been a point which we have not been able to resolve so far, and doesn't look like that we will be able to get so many hospitals in rural and some of the remote areas. So not only in the such pandemic situation, but also otherwise, I think having a remote access to these healthcare services through technology is going to take us a long way.
Great. Thanks. Next question.
Absolutely. Yeah.
I'm going to match your questions.
Yeah. Sure. Go ahead, sir.
So, one is, can we monitor the quality, especially of the red or green, public green zone? And with 80% asymptomatic cases, isn't the green zone a fallacy? You want to take this one? Hello? Simar, I seem to would you like to take this one? How do you monitor the quality of red or orange zone? And given that maximum cases are asymptomatic, isn't green zone a fallacy?
Yeah, so, to be honest, this thing around thermal screening every morning, there's a queue outside each hospital. A lot of people get in. I mean, I have serious doubts on the efficacy of that process also. So you have a couple of people who are employees who downloaded the Arogya Setu app. In Once they are in the lobbies, those triggers and those alarms go off. So I mean, we honestly speaking, so far we haven't managed to crack a foolproof situation. There is nothing called as a green zone. It's either a orange zone or a red zone. So we just have to and needless to say, the hospitals, irrespective whether they are COVID hospitals or non-COVID hospitals, the hospitals are red zones. And right now, for whatever it's worth, it's also around the fact that this, with the unlock happening, everyone has to protect their own selves. This is the key. Be it hospital operators, our staff members, our doctors, or for that matter, patients also. So I
Agree with the
am a
fact
bit
probably
sorry.
the green zones are not. So you agree with the fact that the green zones are a fallacy?
Yeah, there's nothing called as a green zone. I mean, unless you've tested everybody in that green zone and everybody's turned out to be negative, which hasn't happened.
The next question is regarding senior citizens, that in the situation where there's a rapid rise in the COVID cases, how do you propose to reach the senior citizens with comorbidities who are otherwise apprehensive to attend hospitals? It's open for the panel, so anybody can take this one.
Okay, so Prashant, I'll go for it because see, what we have done is we thought through it, and what we have come up with is a home care product, right? So as you know that as it is for senior citizen, we have been deliberating it that there's a huge scope of home care services that one can explore, and fortunately, in last 2-3 years, there are good home care service providers who have come up. So we have designed these home healthcare packages for two category of people. One is that those who remain asymptomatic or mild, and the second one is about those senior citizen again who are asymptomatic or have mild to moderate symptoms. Because in senior citizen, if they already start to show symptoms, I would not advise them to stay back home. They need to then reach out to the hospitals, because as you know that this disease is much more susceptible to the senior citizens. Otherwise, if they have other care or healthcare needs, that can be attended to. Obviously, something like dialysis and all that, we still don't have home dialysis happening, so they would have to come to the hospital. But day-to-day consult, you reach out to your doctors, do teleconsults. For anything else, if you just need a nursing care, nursing can reach to your place. Either you can take somebody from home healthcare services, or you can reach out to the hospitals who are offering these services.
So let me implore you a bit more, Richa, on that regarding dialysis and other patients with comorbidities, the apprehension to come to a hospital, but they have to. So how do they or hospitals handle this situation?
See, as Simar said, that in current scenario, everyone has to take care of themselves. And three things which we have been advocating: one is wear mask the moment you're out of your house, and even within the house, if it is like you have a joint family or something like that, it's not a bad idea to wear a mask. Second thing, your hands should be sanitized all the time. If you're at home, keep washing your hands regularly after an hour or 2 hours. Or if you're going out of home, always carry a sanitizer with you. So these are the two things. And third thing is the social distancing aspect. Because I have seen this, that those patients who were still coming by public transportation, now that public transport is open, they're still taking a cab, wherein they have much more privacy, and also the distance, maintaining distance from the people. So social distancing, wearing mask, and sanitizing your hand are the saviors in this current scenario.
Thank you, Richa. Next question. This question is for me, is regarding the scope for hospital administrative personnel in the private sector. Will it increase or decrease? So Abhishek asked me to take this. I'm going to take this one. Well, it's only going to increase. You see, in the healthcare sector, good or bad, tough or easy, is going to triple in the next 10 years or maybe 15 years. But the pace has to grow. It's a demand which is unmet. It has to grow. And worldwide, if you see, then healthcare has been relying very heavily on administrators. Yes, you need to have specific skills. It's no longer the situation where anybody can just walk in with without a proper knowledge base. So equip yourself well, make yourself knowledgeable, put your heart and soul into it. And I think this is one sector which has taken in people from many other sectors, but no, people just refuse to leave it. I came from the steel background and now I'm in the healthcare sector, and I have no intentions of leaving it by any means. So yes, there is massive scope. No worries about it. It's going to have a good future.
Just can I add a point, Prashant? When you were talking about the dialysis patients, what if there is a kind of a dilemma. We still have a lot of questions which are unanswered, and we are constantly learning. So, like what we are, because dialysis patients are all CKD patients, and they have some of them are ESRD, they have comorbidities with them. So we have started actually testing them on COVID positivity. And we are kind of trying to do it by batches after explaining to them why do they need it. And then finding is that quite a few of them are coming positive. So the dialysis wards, the way we are managing the PPs is you are treating them by PP, but then the dialysis beds are one after another. There may be a 3 feet distance, or but they are there. And if there is a positive patient out there, then you need to be careful. So we are actually getting positive patients in our dialysis pool. We have every hospital would have a certain number of patients on dialysis. So I think we need to work on the dialysis, guidelines and protocol on testing and how they should be dealt with in the future. This will be one of those question marks, like many are. So you mentioned, so that's why I thought some of them are asymptomatic, but they're coming out to be positive.
True, and the fallacy is that between one dialysis session and the next, there's a 3-day gap, and between those two, they can be contact from anywhere.
So what I have done is we have found the 3 patients that we found out. We asked them to get admitted in a hospital and have to be 14 days they passed, and then one of them has actually crossed that 14 days and have tested negative, and we are back to dialysis. So they need to be they need to pass that positivity phase and infective phase and come back to negative. So that's the dilemma.
Somebody who has tested negative, once he comes back for the second session, you can't test them in every session. So how that?
But you have to give a gap of 14 days. So monthly, twice they can be tested. So that's what from our side that we have said to them, that 5,000, about 10,000, keep it with you. Or if the test prices come down or whatever, 2,500, 3,000, keep that separately for you. Like your blood test that you do, you need to also do COVID testing twice a month. Some of them actually are not liking it, but some of them have to accept it. So
I'm sure it is unpleasant for on every aspect. But